ZolifeFest proudly supports cardiovascular education initiatives like CardioNerds. The landmark SCD Protect trial is now published in the European Heart Journal. Using data from 19,500 consecutive LifeVest patients, this independent trial evaluated sudden cardiac arrest in reduced EF patients during the early phase of modern GDMT optimization. The key finding is a substantial early phase risk of SCA due to VT or VF in both ischemic and non-ischemic patients. See the latest results at scdprotection.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey CardioNerds, this is Naima Maqsood, and I'm here with CardioNerds member Dr. Sukriti Banthiya. We're thrilled to present to you another installment of the CardioNerds Journal Club in collaboration with the Heart Rhythm TV. Today, we will be discussing the results of the I-CLAS study with expert faculty Dr. Vijayraman and Dr. Theofanie Mela. Dr. Vijayraman is the Assistant Director of Electrophysiology at the Geisinger Heart Institute in Pennsylvania. He is a pioneer in the conduction system pacing realm and has authored numerous innovative publications in this field. Dr. Mela is an electrophysiologist at the Massachusetts General Hospital in Boston. She is the director of the pacemaker and the ICD clinic at MGH. In addition, she is the course director for the Boston Lead Management Symposium. We're looking forward to getting key insights regarding this study that was presented at the HRS 2025 meeting. Thank you so much for joining us, Drs. Mela and Dr. Vijayraman.
Thank you for having me.
Now I'm going to hand over to Dr. Sukriti Banthiya to kick off this podcast.
That was great. Well, let's see a patient together at the CardioNerds clinic. So, Dr. Vijayraman and Dr. Mela, we have a 67-year-old female, Miss Lee, with non-ischemic cardiomyopathy, an EF of 35%, and left bundle branch morphology QRS with a duration of 155 milliseconds, who presents to the clinic with NYHA class 3 symptoms. She is referred to evaluate eligibility for cardiac resynchronization therapy. And before we get into the management strategies and the therapeutic options in this patient, Dr. Mela, could you provide a brief overview of what CRT is for our more junior listeners?
CRT is a particular type of pacing of the heart that was developed in the early 2000s, or I should say became clinically available in the early 2000s. Years of experimental work had preceded the clinical availability. It involves having two pacing sides for the lower chambers of the heart, one on the left and one on the right ventricle. We have the conventional pacing or ICD lead that could provide pacing. On the left ventricle, we have a lead that is introduced into the coronary sinus in one of the branches, the secondary branches, with the expectation and hope to have that lead in a lateral or posterolateral position in the mid left ventricle. So pacing simultaneously from both those leads, we can provide what we call resynchronization when a patient has issues or problems with that issue. There is also an atrial lead for patients who are in sinus breathing. So there is also AV synchronization. But for patients in atrial fibrillation, you can just perform ventricular resynchronization with the way that I described.
Thank you, Dr. Mela. That was really helpful. Dr. Vijayraman, I'd like to ask you a question. Prior to the results of the I-CLAS registry, what was the approach to managing patients such as Ms. Lee here?
Yeah, so as Dr. Mela pointed out, in patients with left bundle branch block, there is significant dyssynchrony between the right and left ventricle, and the left ventricle is significantly delayed in terms of activation. This electromechanical dyssynchrony is what leads to heart failure in a significant number of patients. So our approach is to use conduction system pacing, and we've been working on it for the last 15 years. And if you look at cardiac resynchronization therapy with biventricular pacing, there's sometimes limitations to that therapy because you may be near a phrenic node, sometimes you're near a scar and the thresholds are high. And sometimes it's very challenging to get a lead into a good location. And we may not get to a lateral location because there's no good venous branches there. So the ventricular resynchronization may not always be fully resynchronized in these patients undergoing biventricular pacing. So when we learned that his bundle pacing can completely correct a left bundle branch block, we know right at the time of implant itself, we can fully resynchronize. Because we normalize the left bundle branch block, then we know we have adequate cardiac resynchronization. But there was some limitation with his bundle pacing. So we chose, as technique developed, we ended up doing left bundle branch pacing so we can get into the proximal left bundle branch, just beyond the site of block. So now you can have thresholds that are pretty good, like less than 1 volt on a consistent basis, and you resynchronize the entire left ventricle. And we know right at the time of implant, we've got full resynchronization. If the heart failure is due to dyssynchrony from left bundle branch block, we can pretty much be sure that we can normalize that. And so our approach changed to using this. So in this patient, we would first start with his bundle mapping with the pacing lead and pace at a high output, see if it completely corrects. Then I would move on to left bundle branch pacing. The idea of using his bundle pacing is that there are many patients with left bundle branch block who have IVCD, diffuse left-sided conduction delay, that masquerade as left bundle branch block. Those patients generally do not do well with either biventricular pacing or left bundle branch pacing. So we know which those patients are by trying to map the his bundle. And so if it's correctable, then I know I can do left bundle branch pacing, and that would be our approach. And that's what we tested in the I-CLAS study in a multi-center fashion, but it was a retrospective study.
Thank you for those comments. And on that note, let's go over the findings of the I-CLAS study. So the left bundle branch pacing I-CLAS was a retrospective, multi-center, observational, case control study designed to evaluate the real-world outcomes of biventricular pacing and left bundle branch area pacing in patients with an EF of less than or equal to 50%. The patient population included adults with NYHA class 2 to 4 symptoms, an LVEF of less than or equal to 50%, an indication for CRT, or anticipated significant ventricular pacing, which was defined as greater than 40%, and in whom successful CRT was achieved with biventricular pacing or left bundle branch area pacing at 18 international centers from January of 2018 to June of 2023. The intervention in the study was biventricular pacing or left bundle branch area pacing based on operator preference or the clinical practice at the participating institution. The primary outcome was the composite outcome of all-cause mortality or first heart failure hospitalization, and the secondary outcomes included individual outcomes of all-cause mortality and heart failure hospitalization. A total of 2,579 patients met the inclusion criteria, 1,118 of whom received biventricular pacing and 1,461 who underwent left bundle branch area pacing after propensity score matching. 1,560 patients were well matched. 780 received biventricular pacing and 780 underwent left bundle branch area pacing. The primary composite outcome of heart failure hospitalization or all-cause mortality was significantly lower in the left bundle branch area pacing group compared to the biventricular pacing group. This was 20.5% versus 29.5%. And the secondary outcomes, which included individual outcomes of heart failure hospitalization and all-cause mortality, were both significantly lower in the left bundle branch area pacing group as compared to the biventricular pacing group. 12% versus 20.8% and 11.7% versus 17.4% respectively. Dr. Vijayraman and Dr. Mela, how does the I-CLAS study add to what we already know about left bundle branch area pacing CRT? And would it change our treatment strategy in this clinical scenario?
Maybe I can go first because my response is going to be shorter, and then we are going to let Dr. Vijayraman take us through the 15 years. I thought that they were even more, the 15 years of really developing and promoting this new conduction system pacing, of which he is one of the pioneers. But from the point of view of a clinician in a busy clinical center, certainly a study like the I-CLAS study adds to the information that we had before. And I should say that most of the data that we have and the studies that we have come from Dr. Vijayraman's group. showing a very positive trend for improved outcomes in patients who receive conduction system pacing. But from the point of view of the clinical center that has not been part of the studies or the early onset of conduction system pacing, I can say that we are still becoming familiar and better with this technique. And we also continue to understand more the nuances of this technique. And we are on a day-by-day learning basis, knowing that the outcome can be as good in terms of our patient, the clinical scenario that you presented, as CRT, biventricular pacing, as we call it. We always have this approach as the backup plan rather than our first approach in most of the cases. The guidelines that we follow these days, the classification of indications for what device your patient in the CardioNerd clinic should be getting, say that it's a class 1 indication for that patient to receive a CRT device. So we would always start with the CRT, and only if we had a technical issue, as Dr. Vijayraman mentioned before, of lack of an appropriate branch or inability to access the coronary sinus, or even if we put the lead where we would like it to be, we are not able to get good electrical parameters, we would have the conduction system pacing as a backup option. I will stop here because I'm sure that we will talk more about the future of this approach a little further down. And I would say that it's all positive and optimistic.
Yeah, Dr. Mela put it very nicely that biventricular pacing is the class 1 standard, and that is the guideline recommended therapy for this particular patient. So I would strongly encourage most clinicians to go for biventricular pacing. But as Dr. Mela also mentioned, in the past, we didn't have a choice. So if you had a bad vein, or you had high thresholds or phrenic, now we accept it because the alternative was to send the patient for an epicardial surgical lead placement, which has higher morbidity. Now we can easily cross over to the backup plan if we don't have the idea. We know from years of work from Dr. Mela's group and others that you need the LV lead to be at a site where there is the latest ventricular activation. So the most dysynchronous place is where we want the lead to be. But sometimes you're at the mercy of the branch and you don't have good, what we call as QLV, the timing between the onset of QRS to the LV. Then we should have a low threshold to cross over to conduction system pacing. But of course, you need to be familiar with the technique and do it right, because then bad left bundle branch pacing is a lot worse. Because if you don't get left bundle branch capture, so we are learning the hard way. Many centers in some of the newer studies have shown that if you don't get left bundle branch capture, the outcomes are not going to be good. You must be good at biventricular pacing because that should be your first choice. And if you don't know how to get left bundle branch capture, you shouldn't be doing left bundle branch pacing. That's a challenge because many centers simplified the technique to achieve left ventricular septal pacing or deep septal pacing. Sometimes it's very hard to differentiate. And if you do that as a first line, then you may be doing disservice to our patients. So biventricular pacing should be the first choice. But at the same time, if we can familiarize with the technique and show that you can get to the proximal left bundle and get left bundle branch capture, prove that because we have a lot of electrical parameters to confirm that, then that approach may be as good, if not better. Before I move forward, I want to emphasize this particular study was a retrospective study. So all the limitations of a retrospective study, all the bias from the operators, and especially selection bias, because this was on treatment analysis. So, for example, if you did biventricular pacing, was a bad, severe cardiomyopathy and couldn't get it, then we did left bundle branch pacing. Or you could have had a left bundle branch pacing and then you fail because it wasn't a true left bundle branch block and then did biv pacing. So there's all kinds of bias that this may lead to, but nonetheless, it's a large study. It gives us hypothesis generation to show that left bundle branch pacing may be as good, if not better than biventricular pacing. So we have to wait for randomized clinical trials to convince everybody that that's the approach and then do it the right way.
That was really great, Dr. Vijayraman. So I think our takeaway is that These results are very encouraging, and left bundle branch area pacing may even be better or as good as if done right. So I think keeping that in mind for trainees is helpful. So as far as what happened to our patient in the clinic, Ms. Lead underwent cardiac resynchronization with biventricular pacing. As you all recommended, the CS lead was placed in the posterolateral branch overlying the mid LV. The QRS duration was 136 milliseconds after optimizing for RV and LV pacing timing, and she felt well post-procedurally and was discharged. At the 3-month follow-up, her LVEF, however, was not improved. After ensuring that there was not a reversible or correctable cause for CRT non-response, Dr. Mela, would you deem left bundle branch area pacing to be a reasonable alternative in this setting?
First of all, let me say that I am surprised that this patient is a non-responder because she's really the ideal patient for CRT. And she belongs in the category of patients with non-ischemic cardiomyopathy, female gender, left bundle, wide QRS, that their response is usually remarkable and they're usually the hyper responders. But in any case, the fact that this particular patient was a non-responder does not necessarily make me think that we should proceed with a revision of her system and offering her a left bundle area pacing lead, because I think that this is a little bit of an uncharted territory. So reoperating on the patient and exposing her to the risk of reoperation, which includes infection or other technical issues, may not be really supported from the data that we have up to now. So in this particular patient, if she were to be a non-responder, we would still try to optimize her guideline proposed medical treatment and also consider her for more advanced heart failure management rather than necessarily trying to offer her a left bundle area pacing lead. But I'm really very curious to see what Dr. Vijayraman would have done.
Thank you. No, Tanya, you are absolutely right. And normally we would expect this is the patient. I probably would have said before the procedure, you're going to be a responder or hyper responder sometimes, especially women with left bundle branch block, a wide QRS, low EF, they do well. But there are two things that as fellows in early career cardiologists need to understand. One is left bundle branch block induced cardiomyopathy, and the other is left bundle branch block associated cardiomyopathy. In patients whom we have left bundle branch block and then develop cardiomyopathy, the answer is very clear. You correct it, those patients are going to do well. But many times we see patients come with left bundle branch block and cardiomyopathy, so we don't know chicken or the egg. And good number of them are actually left bundle branch block induced cardiomyopathy, and they are the hyper responders and do well. But there are many patients who develop diffuse conduction disease, IVCD, which looks like a left bundle branch block. And this patient, judging from your description of a nice posterolateral mid-ventricular branch and a pace QRS as a 130, looks like was reasonably well synchronized. First step for me to see is it reasonably well synchronized? One is we'll check the QLV. We'll see, can we avoid RV pacing? Can we just do what we call as adaptive LV only pacing? And there are a lot of optimization that, especially MGH, Theofania's group had done. If you do combined heart failure and CRT resynchronization clinic, many patients who are previously non-responders become responders because there's a lot of little things that we can make sure the patient has high degree of biventricular pacing, there are no arrhythmias, no PVCs, and the lead and the LV timings are optimal. So we do that first. If all that looks good, then my suspicion would be that is it a true left bundle branch block? Can we understand this some way? There are some invasive studies we can do, left-sided mapping, to see if it's left bundle branch block or IVCD. And if it is a true left bundle branch block, then I would like to have an MRI to see if this patient has scar. If they have significant scar, this is an advanced, some kind of infiltrative scar cardiomyopathy that may or may not respond to even left bundle branch pacing. Because if your BIV is done well, I think left bundle branch pacing is going to be only providing similar benefits. But we have done a study on patients who failed BIV and patients who are non-responders to add left bundle lead and sometimes combine both forms of therapy, left bundle plus coronary sinus. We call it LOT CRT, left bundle optimized cardiac resynchronization therapy. Sometimes with his bundle plus LV combination called hot CRT. So those are options. And so we really have to investigate this patient. Does he have a true left bundle branch block? Is it an advanced form of different kind of infiltrative type of cardiomyopathy with CAR? Because BIV, when done well, usually results in good response. And one last point is that, while 3-month echocardiogram may not have improved, there is a new concept called non-progressive. So you may be a non-responder is a late concept that comes after you watch for a while and they get worse. But non-progressive is somebody who don't get any more heart failures, who do well, even though the EF may not improve. And so that's one thing. And then we also see patients who, depending on how long the cardiomyopathy has been, how left bundle branch block has been, and it may take, instead of 3 months, may take 6 months, 12 months for that ejection fraction to improve. So I wouldn't discredit the BIV pacing so quickly.
Thank you so much. Those were great answers. I think we got a lot of food for thought for our listeners and viewers. So we've, in this few minutes, covered features in a patient that may suggest that they would be a good responder or maybe a super responder versus not. You mentioned being more thorough about patient selection when you're considering someone for cardiac resynchronization, making sure you actually consider someone that has a wide QRS, preferentially a true left bundle branch block. So that's super important takeaway from this discussion. The other thing that I loved, Dr. Vijayraman, that you mentioned was making sure the reason they didn't respond was not that they already had such advanced cardiomyopathy and such extensive scar, maybe that they were not going to respond in the first place. I think those are also important things to keep in mind. And then I like this idea of not disregarding it within 3 months. Maybe that patient might take a little longer to recover their EF. And even if they don't recover, just being non-progressive and maybe not having as many heart failure hospitalizations might be a good endpoint as well. Thank you so much for that. That was great. Awesome. So Miss Lita's happy and doing well. We'll follow up with her in about 3 months again. Now we're called in to see a patient who was just admitted to the ICU. Mr. Pace is a 75-year-old man who developed complete heart block after an implant of a self-expanding transcatheter aortic valve for severe symptomatic aortic stenosis. He has a preserved EF of about 60% on his most recent echo, and a temporary pacer wire was placed, and he's had ongoing complete heart block for the past 3 days. Dr. Vijayraman, is there a role for CRT in this scenario? And if yes, what would be your preferred modality?
Now, current guidelines for patient with LV ejection fraction above 50% don't place biventricular pacing as a high enough indication in the guidelines. But if the patient has significant heart failure, then sometimes you're tempted to consider biventricular pacing because you have a patient who's going to be 100% pacer dependent and just recovering from an aortic valve procedure, and LV is going to be stiff. And we don't want to cause RV pacing induced heart failure. But for this particular group of patients, we have enough evidence now that many observational studies and 3 small randomized studies compared right ventricular pacing versus left bundle branch pacing or his bundle pacing in this particular patient population, and shown to have early evidence that there's reduced incidence of heart failure hospitalization and in development of pacing-induced cardiomyopathy. So I would choose left bundle branch pacing as a first-line option. We can just do a regular dual-chamber pacemaker in those patients. And if we are unsuccessful, then consider biventricular pacing if the patient has significant heart failure history. So that would be my approach.
Thank you so much. What would you do in this situation, Dr. Mela?
So I would agree that offering this patient conduction system pacing will probably result in better outcomes. My first concern about this patient is that with right ventricular pacing, he has at least a 10% chance to develop pacemaker-mediated cardiomyopathy, which we see frequently among our patients when we don't do conduction system pacing. And then you have to go back, usually within a year or sometimes 2 years or 3 years, to upgrade their device to the appropriate device. I also agree that there is some evidence. Again, it's more observational evidence that these patients do better, even if they don't develop pacemaker-mediated cardiomyopathy, but overall, their outcome can be better with conduction system pacing. We did run actually a small randomized prospective trial in Boston. We called it Boston PACE trial, and we're still waiting the results of that study to come out to really answer this kind of questions. I have the feeling that to definitively answer this question, we really need longer follow-up than the 12 months, but we will wait to see more. Finally, I should say that from a technical point of view, especially for the advanced age patients that end up receiving, let's say, the TAVR, the scenario that you gave, especially small elderly women, actually we do prefer to place the lead in a septal and hopefully more than septal left bundle area pacing position, so to avoid perforation, which used to be much more frequent when we were not using this technique. So for all of the above reasons, we would have done the same.
Amazing. Now, let's consider another patient. We have a 50-year-old male with hypertrophic cardiomyopathy, EF of 35%, and left bundle branch block with a QRS duration of 160 milliseconds. Doctors Mela and Vijayraman, in a markedly thick interventricular septum, or in cases of scar in the septum, such as patients with an MI, cardiac amyloid, or HCM, how feasible is left bundle branch area pacing, or would biventricular pacing be the preferred approach?
Yeah, so hypertrophic cardiomyopathy and LV dysfunction definitely is a difficult group of patients because for two reasons, all right? One, the septum is quite thick, and the septum just not thick. It's also may have interstitial fibrosis, which make the lead implantation challenging. We've had some small series which have shown that left bundle branch pacing lead implantation is feasible in this group, maybe not 95% success, but probably in the 70-80% success. Depending on the substrate, where the scar is, a lot of things. What we also don't know what happens in the long term when you have that much length of the lead intramyocardially. Does that lead to any kind of lead integrity issues in the longer term? And also concerns regarding lead extraction, thick septum when the lead is there. So all those things have to be considered. And there are two options. We often try for good BIV. If not, we often have his bundle pacing as an option, knowing that the threshold rise or high thresholds to correct the left bundle branch block is an issue. One of the pioneers of left bundle branch pacing, Dr. Weishan Wang from China, he's come up with a new technique, Dr. Mela, that I had the privilege of him coming to our lab and showing us how to do it, and I'm still learning. So it's trying to do distal bundle pacing, same as doing left bundle branch pacing, but deep septal, but in the proximal high interventricular septum, where the septum is not as thick in the first few millimeters. So he has done that specifically in this hypertrophic cardiomyopathy patient because he can get to the left side of his within about 7-8 millimeters. A distal septum is about 20-25 millimeters thick, and you can get from the base of the tricuspid to just get in there. So that's a very challenging technique. I've only done 3 cases out of 6 that I attempted, but we are able to get to the really proximal left bundle branch. So those are new techniques, new tools may be necessary to do. But biventricular pacing would be the first choice in these type of patients. And then if you fail or have challenges, then doing conduction system pacing is a reasonable alternative approach.
The one concern that I would have, I don't have a lot of experience because we only have so many patients with hypertrophic cardiomyopathy that require cardiac resynchronization. From my limited experience, I find it more difficult to be able to advance the lead into the septum, or even when and if I do that, for that position to be stable, as if the septum is different than other septa that we deal with. But again, this is limited experience. As far as the technique that Dr. Wang is suggesting, obviously, we're going to be listening to him because we know that his thinking is very novel and he really created this field of left bundle area pacing. My concern with hypertrophic cardiomyopathy patients is the evolution of the consistency of the septum, especially in younger people. You can see the thickness increase even within a small amount of years. So in addition to how the lead will behave, I would be concerned about how the septum and how excitable the septum will remain, whichever position we have obtained, and really make sure that the patient is being paced optimally long term. But it remains to be seen, and hopefully we will have a series soon that will give us some insight.
These are really exciting advancements. Looking ahead, Dr. Mela and Dr. Vijayraman, what are the key evidence gaps that must be addressed to reassess the guideline indications for biventricular pacing versus left bundle branch area pacing?
So, I mean, we've touched upon many of those things. It's an evolving technique. So, we'll highlight some of the limitations and where we need to go. Left bundle branch pacing has morphed into the so-called left bundle branch area pacing. And so having clarity on what is left bundle branch pacing and what is non-left bundle branch pacing is how I'm looking at now, because many physicians do deep septal pacing and sometimes LV septal pacing and assume that to be left bundle branch pacing, which is a misservice to our patients. Recently, there was a randomized study looking at IV versus left bundle branch area pacing in Brazil, and the outcomes showed that the so-called left bundle branch area pacing showed significantly worse outcome. Death, heart failure, hospitalization was worse in a 180 patient study. So even in that small study, but the number of patients who had true left bundle branch capture presumably was very, very low in that study, maybe 25% at best. 65% had left bundle branch area pacing in that study. So it's important that people learn to do it well. And challenge is that the criteria is somewhat muddled, and we have to approach this with a lot of rigor when we do these procedures and adjudicate accordingly. That's one part. The second part that's again emphasized the need for good randomized clinical trials. So without proving, and just because physiologically, theoretically it makes sense, doesn't mean outcomes are going to be different. We have some evidence suggesting it may be, but that's hypothesis generating. So thankfully, there's a lot of small randomized trials. And at least I can highlight two large randomized trials that are ongoing. One is called Protect Heart Failure, which is for patients with LV ejection fraction above 40% and those who need ventricular pacing. And so this is between right ventricular pacing versus conduction system pacing. It's done in Europe from England, London, and it's about 2,100 patients. And goal is to prove death or heart failure hospitalization outcome with a 5-year follow-up, which hopefully will have an answer in a few years. And another one is the left versus left trial. That is for patients with LV ejection fraction, less than 50% and an indication for CRT. And I'm part of that trial. It's run by Dr. Ellenbogen and Mikhail Cholu from Baylor and VCU. And that's a 2,300 patient study to show death or heart failure hospitalization, or the type of study we need to see. And comparing IV versus CSP, it's a 5-year follow-up. So we have a long way to go. And so those studies are important. So two things: we need randomized evidence. Number two, we need absolute good, solid evidence that we have conduction system capturing these studies.
I couldn't agree more. We're also part of the left versus left, and I think this is the kind of evidence we need. I also feel that, as with CRT in their early days, when we didn't know all the nuances that we subsequently discovered, even 10 years later after doing CRT, in terms of the position of the lead, or even with the expansion and advancement of the technology and being able to have quadrupolar leads, being able to pace from employ larger amount of myocardium with biventricular pacing. All those techniques subsequently added to our ability to have a patient respond. I want to hope and wish that something similar will happen with the left bundle pacing. I will even omit the word area pacing because Dr. Vijayraman is getting very strict there. I think having an easier way to know that we are successful or not is very important. It is one thing to have these procedures done in experts' hands, in patients with a lot of experience and time to do those. And it's another thing to ask people to do these procedures in smaller centers when there are 8 more procedures waiting to happen in that particular room. So I think we have to have better leads, being able to really perforate the septum better, and also better endpoint or ways to know that we have achieved the endpoint. So for this procedure to be done correctly, I am sure that it will happen because I have witnessed it happening with CRT, but maybe we're not completely there yet.
Thank you for those wonderful comments. I think that really speaks to all the work that needs to happen and hopefully will happen in the next few years. Going back to some of the points that you guys mentioned about adjudication criteria, currently in your lab, when you're doing a conduction system pacing implant, specifically a left bundle branch pacing implant, what criteria do you find more helpful? The ones that I've found to be more helpful are like transition when you're doing a threshold test during the case, if you're able to find a left bundle branch potential when you're using the calipers to actually look at the signal. What other adjudication criteria are more helpful than others currently?
Yeah, so very important point. So for us, the transition is the absolute gold standard and showing proof that you have capture of 2 different tissues, all right? One is the left bundle, the other is the LV septal myocardium. And so that is critical for us. So in our lab, we can get that to be demonstrated in more than 90% of the patients. So proving that there's left bundle branch capture is important. And secondly, we also, in patients who don't have left bundle branch block, right bundle or narrow QRS, then you almost always demonstrate a left bundle potential. And seeing a potential doesn't mean it's proof of capture. So you need to still prove. You may be adjacent to left bundle, but not capture it. So those 2 are important. And the one additional thing I do in almost every single implant is we always identify the His bundle, paste the His bundle. It helps us guide where to go next for left bundle. And it also gives me an endpoint in terms of when I paste the His bundle, I know what's my so-called R-wave peak times in V5, V6. And let's say if I have a left bundle branch block and I always 90% of the true left bundle branch block, I can correct with this bundle pacing at a high output. All I need is a single beat to see, and then look at what is my peak R-wave times in V5, V6. And when I do left bundle pacing, it has to be at least 10 milliseconds less than that. And that most of the time can help eliminate LV septal pacing, especially when you pace from proximal. But just if it's longer, we know we don't have left bundle pacing. So that's another way to prove to ourselves. And so those are the things that we stick, and we don't hesitate to try multiple times. And as Dr. Mela said, you need the time and the effort to be able to do it and the expertise to do it, because you get better when you do more, you get faster and you know what your endpoints are, where to go quickly, and you're troubleshooting, you have a list of things to do. But tools are getting better. Now, significant improvement. There are multiple vendors with all kinds of sheets, and there are dedicated leads being developed both for pacemakers and defibrillators now. Can implant a defibrillator lead in the left bundle branch location. It's been gone through clinical trials. I was the PI for one of the trial we completed. We can hopefully present the final results of that. And there's another trial with a styler-driven lead that's ongoing, and that's so far looks promising. So a lot of help is on the way, new tools, and hopefully that'll change how we practice in the future.
Awesome. That's great. Thank you so much for such a wonderful discussion. I think we really covered a lot of different aspects about resynchronization, and I think it'll cater to some of our junior listeners as well as some EP fellows and early career faculty. Thank you so much both for your time, and we look forward to having you guys again, hopefully for a future episode.
Thank you very much. That was really enjoyable.
Thank you, Naima and Sukriti. Good luck to you all. A wonderful program that you managed to pull off.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Grace Chu. I'm an intern in the CardioNerds Academy, House Jones, and medical student at Thomas Jefferson University. Check out the episode page for show notes and references. If you found this episode or show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episode. And now, my friends, it's time to make like an S2 and split.